Hello, everyone. Good evening from Chicago, where both Howard and I are based. Although we would have absolutely loved to join you guys in Singapore. I was just thinking the last time I was in Singapore was when I went through there on my honeymoon. And that's actually probably many more years ago than you would guess. And it's probably not safe to say that in the house. So we are delighted to be with you. We really appreciate your interest in this session, which we think is of fundamental importance, especially to any actuary working in healthcare and in life insurance. And we'll tell you why. And we've spent many years on this. So I'll give you a quick backdrop to the work that we've done. We really started doing it in the late 2000s. It was at the time when discovery vitality data started to emerge strongly on people more engaged in vitality showed, especially on our health plan, showed better claims experience on the big claims diseases, especially on the in-hospital side. And we saw the right preventative behavior. So preventative utilization and cost went up, especially in-hospital cost went down. And we started to see both on a cross-sectional and on a longitudinal basis similar results on our life block. But it was still early days. And you can think about it similarly to if you as an actuary look at evidence in the market. And there was actually some of that evidence last week when there was something published on JAMA Online that said on one of the really interesting topics of people walking. So if people walk more than 7,000 steps relative to people that don't work 7,000 steps, the mortality in general for the more active cohort, or the hazard ratios are 50 to 70% lower. And then if you as an actuary go and say, oh, that's interesting, let's look at nutrition. So you can look at the comprehensive nutrition elements, and you can see that comprehensive nutrition and the right nutrition lowers mortality by 56%. And we can get very excited because that means if we put nutrition and physical activity together, we can start getting to immortality. But we know that's not the case, and I can see Howard laughing. So Howard and I we've been working on these relationships since probably about 15 years ago. And it's specifically for that reason. Howard's always kept us very honest around, we don't have all the data, we don't have all the environmental exposures, we don't have all the modifiable and metabolic exposures people have. So what is a good structure to bring everything together and also look at our own data from that perspective? We started talking about this around that same time, and we started to talk to actuaries about this, and it was actually quite interesting. There were two things I think that stuck in my mind. One is insurance companies at that stage, and actuaries as well, were kind of a bit confused. Why should we care about this? Why should actuaries or health companies or life companies care about it? We are on the job of financing. If something happens to someone, we finance that. We pay their claims, their death claims, disability claims, etc., and we protect their families. Why should we be involved in someone's health? Is a good question. That has changed a lot, and I'll talk about that at the end of the presentation. The other thing that we discovered is, as actuaries, we're not going to figure out the entire puzzle. And over the course, we linked up with the great people at IHME. So you'll know IHME probably mainly now from the work they've done with COVID. IHME has obviously been very proactive on practical COVID projections. But we loved working with IHME because they're very diligent about these complete risk panels, which Howard will talk about later. And they're also very practical. They're practical like us. I always find actuaries have to be practical because we have to give answers. We have to estimate risk. That's our job. These good epidemiologists at IHME, they've got the same job. They have to estimate disease, and they're very practical about it. So it made a good marriage. So we started going deep in this work in 2015, and it was really a 4-year project that Howard's going to give you detail on. And it was very, very complicated to do all of these things. The one thing, as shown in the title here, is we are talking about the USA, which is of interest, obviously, to anyone in the USA. But it's also important from the perspective that this structure can be applied ubiquitously. We've got information on the risk factors. Bringing the costs together was a big element. So wherever you've got detailed information on cost and outcomes, one can actually apply the structure. So it fits well into the theme of the conference, where it's global but local application, which is one thing I'll mention. So I'll get straight into it. We want to talk about three things. So chapter 1, we're going to talk about the associations between the risks. I'll cover that, how it will take the attribution and talk you through really the guts of the paper and the observations. And then really importantly, we want to get back to applications, because all of this stuff remains theoretical if we can't talk about how to make it practical. So I hope that sounds good, and I'll get into the first bit, which is just the importance of modifiable behavior and how that relates to risk. And I'm just going to set up some concepts that Howard will talk about in a bit more detail. But let's start at the start. So if as an actuary you ask what is the most predictive element for mortality or morbidity, your answer is going to be age. We can't get away from that. Disease comes with age, more illness comes with age, death comes with age, and disability and disability impairment comes with age. But there's a lot we can do about that. And that's really fundamental to, I think, the opportunity here. This is from a paper from James Fries in 1983, so almost 30 years ago. And the concepts have not changed, and we're still seeking to achieve this. So if you look at the progression of disease, and this applies if you on long-term insurance or you're in short-term insurance. Long-term, you're going to look at the pathway. Short-term, you're going to look at the cut. So there's no actuary that can really say, oh, this doesn't apply to me because I'm in health insurance, I look at the stuff every year and so on. The population you get every year is a cut of this population, and it really matters where you cut them and how they come into the population and then how you keep them. What we often forget in health businesses is that even though there might be annual businesses or short-term, even some shorter than annual, so for most of these businesses, and we really try to be good at it, I think in general, is to retain the people. So in essence, your short-term businesses also can become long-term businesses, and you need to think about it both in cross-section and longitudinal views. But the point here is disease comes with age. There's a natural pathway, and it hits you, and it leads to early death at the end of the line. Or we can postpone disease. So you still get manifestation of disease. You get glucose going up. You get diagnosed with diabetes. You die of heart disease related to diabetes, for example. Or we can prevent disease. And that's really the holy grail. So here, preventing the disease is all our risk factors go up with age. Our blood pressure, glucose, all of those things. We tend to eat a bit better. Smoking goes down with age. We don't exercise, and we're not as fit as we age. So, but all those things push our risk factors up. Prevention here means there's no clinical manifestation. So your risk factors go up, but they don't actually cross kind of what we would consider a clinical or symptom threshold. I just wanted to state that in terms of the importance of thinking about the long term, even if you've got cross-sectional business. This we're not going to go into detail, but it's important to understand that what we really talk about here is we go from your behaviors to your risks, to your conditions, and to your deaths. If you're a life insurer, for example, you focus on the end. If you're a health insurer or long-term care, all of those businesses, you focus on the second column from the right. But all of these things matter, and they're all interrelated. There's been a version of this floating around on social media today, which comes out of the Society of Actuaries paper. We've got a link there. We simplified, we did this work for the Society of Actuaries. It was published last week. We simplified the structure So you don't see all these numbers, but in essence, if you want to learn more about these relationships and also the interventions and where the latest science is, please feel free to read the guide. In terms of thinking about these relationships, I'm just quickly going to talk about diabetes. And diabetes is a really big deal. In the US and around the world, diabetes over the last 2 decades have been one of the 2 drivers of medical care cost. It impacts a lot of people. You can see that the latest statistics that we pulled last week is it's reported that 45% of the US population is now either diabetic or pre-diabetic, so moving up towards diabetes. We've seen the incidence increase and the prevalence increase over the years dramatically. And then the question is, okay, what does it relate to? Are there some lifestyle risk factors that are causally linked to diabetes, and how big are they? And you'll likely already know this from your own work. So overweight, obesity, glucose pathways, physical activity are direct links. We just simplified this. This is some of our older work, but you can see these linkages. Now, then the next question is really, okay, if we see these linkages, what does that mean in terms of quantification? Can we actually quantify some of those things to get to the attributions? So to do that, we really need to, if you look at the left-hand side here, we critically need to look at 2 things. One is we need to look at what is causal. So we already said that there's some causal relationships from risk to diabetes. Secondly, once we've established causality, we can say, how do we quantify these things? And the quantification gets tricky because, as we show at the top here on the right-hand side now, there are relationships between these risk factors. So some are mediated. So BMI would impact blood pressure here. Just as an example, would go to ischemic heart disease. Same diet would impact blood pressure. Diet would actually impact BMI as well, which is not illustrated here. So we need to take that into account. But then from epidemiology, we can see that overweight and obesity, just going down to the middle right-hand side there, has a population attribution fraction, which is really the proportion of the incidence of the disease that's linked to the risk factor. So it's got a population attribution factor of 76, physical activity 15. So does that mean that if we look at overweight, obesity, and physical activity, we can now causally link 91% of behavior, or causally explain 91% of diabetes? And the answer is no, because these things are obviously interrelated. So then we get to the joint population attribution factors, which is a complicated process to get there. And you can see here, just for these 2 risk factors, if you compress them, they causally are linked, or the PAF attribution is about 79%. So hope that makes some sense. This is the last background slide before I'll hand off to Howard. Just some other concept. The cost of illness is going to be known to any actuary. The attributable cost of the illness is that portion of the illness that relates to a heightened risk factor. So risk factors, you know what those are. And then something we're actually not going to talk about in detail today is the avoidable cost of illness. I mean, you can think about this maybe just simplistically by thinking about smoking. So if the population stops smoking today, are we saying there's no higher risk for lung cancer for that person or the part of the population that's smoking? That's not true. These things, if you want to reverse them, they take time. It's not something we'll cover today, but it's important to incorporate as you think about your own thinking. So, Howard, with that, I'll hand over to you to talk to us about how we've taken that, applied it to the US healthcare system, working with IHME data, and are there meaningful insights coming out of that?
Yeah, thank you, Francois. First of all, it's a real pleasure to be back in front of the IAA health section. I think one of the things I'm proud about in my career was having been the founding chairman of the section, and seeing it continue to thrive makes me really proud. So thank you for inviting me. what I'm going to do is really fairly compressed. I'm going to kind of introduce you to the concepts or some of the specifics that have been done and do a whirlwind tour through what is an enormous amount of data that you can access yourself and play with. Now, Francois mentioned that we're working with IHME. If you go to the next slide, please. There we go. IHME, the Institute for Health Metrics and Evaluation, has been around for quite a while. In fact, this whole project of the global burden of disease grew out of a relationship they had with the World Health Organization in the early 1990s. It's now a center at the University of Washington in Seattle, Washington, here in the US. And what they now do is they come up with these global burden of disease studies once every year. It's an enormous study. I'll give you some references to it, but behind it is what's so impressive, that what they've managed to do is organize over 7,000 researchers from more than 156 countries to look at some of the details that go into their model. And what they've been doing is quantifying the health loss metrics. They look at 280, the current version, which was in 2019, looks at 286 causes of death, 369 diseases and injuries, and 87 risk factors. And they do this not just for one country, and we'll be presenting some data from the US, but they do this for 195 countries from around the world. The key thing we're looking at is their comparative risk assessment, which is a comprehensive model of the causes of mortality and morbidity related to these 87 risk factors. And they do this over time, so you can track what the flow of changes over now decades, because their data goes back to the early 1990s. The GBD, comparative risk assessment, is a model. I want to emphasize that it's a model which aggregates and integrates causal relationships with the risk factors that are related to them. And it's based on, the model is based on a great deal of work done by these 7,000 researchers in terms of aggregating, studying, and coming up with recommendations that fit into the model based on the epidemiology and clinical literature. All the data, the methodologies, the analyses, and some visualizations, some of which I'll be sharing with you in just a minute, can be found at the website, which is referenced there. And the IHME teaches a course in their model. It's a week in Cyprus, and obviously I don't have a week, so I'm not going to be able to go through more than just wetting your whistle, letting you know what can be done with this, and hoping that by giving you the reference to IHME, you'll be interested enough to go there and play around with the data. It's endlessly fascinating to those of us who are actuaries in life insurance and health insurance. Francois, the next slide, please. This is the kind of overall picture of the work that's been done. There were 5 papers that really kind of end up with the work that we did with IHME, which is on the right. First of all, every year they publish a special issue in The Lancet, which includes the first 3 papers. The first 3 papers are looking at the death by the 282 causes of death in all the countries. So it's just simply breaking down the data, collating the data, putting it into cause of death in each country. And again, it's population data. Second paper looks at the burden of disability with a measure that they use called years lived with disability. And they do that for 345 causes of morbidity. Then they take both the life and the death and the morbidity, the mortality and morbidity, and they relate them to the 84 modifiable risk conditions based on causal relationships. And they're very, very strict about being certain that relationships are causal, not bidirectional, not correlational. That's why these 7,000 researchers really spend a great deal of time looking at each element of the model. So that then is kind of the base from the global burden of disease. A parallel study done by IHME is the third paper published in JAMA, which is looking at the cost of healthcare in the United States, the healthcare spending, and breaking it down, the national health income accounts, down into each of 350 diseases and injuries. So that's a parallel project which informs people about how much money is spent on each disease, and it's also broken down by payer, excuse me, by where the money is spent. Is it inpatient, outpatient, so on and so forth. And what we did with IHME is we came in while the US healthcare expenditure survey was being done, work with those people to combine the information they were gathering on the cost of disease within the United States by disease with the risk factors in order to estimate the percentage or the proportion of spending in the United States that was attributable to modifiable risk factors. And that's what was the end product, which was published in the Lancet Public Health, excuse me, late last year. Francois, next slide, please. So the morbidity, mortality, risk factor data is just gathered from all over the world. We're going to focus in on the United States. And the ability to do the last piece, which we're talking about here on healthcare spending around the world, is rather limited because it's difficult to gather the data about the costs by disease. So they were able to do it in the US, but as Francois kind of hinted at, this really took about 4 years to get the study done. It's an enormous information gathering problem and then integration problem and definition, but this is the work that was largely done at IHME that we built off of. The causal relationships are based on work that was done by the expert panel and some additional work that we did to try and relate it to healthcare costs. You can see in the next piece, the various pieces of the puzzle that are produced by IHME. There's deaths, there's a variable called years of life lost. It's a mortality risk. There's the prevalence and incidence of morbidity. There's years of life lost to disability, which is a morbidity measure. And then the sum of years of life lost, mortality, and the morbidity, the years lost to disability, is a disability adjusted life years. All these data are available, and the definitions, the specific definitions and the detailed data are available on the IHME website. But what we're doing is looking at, in our case, healthcare spending in 2016, broken down by disease in these 200 and some odd disease things, and answering the question about if there had been no history of heightened risk factors in the United States population, how much lower would the spending have been on each of the 200 and some odd diseases? So it's related, it's historical counterfactual, that's the way the model is built. And the other important thing is the joint effort. You know, as Francois showed with the diabetes, you've got to be able to understand the interrelationships of among the risk factors in order to not overcount. And this is a problem that we see quite a bit when companies or other kinds of studies try and duplicate this more complicated model. They look at the individual pieces, for instance, with respect to heart disease, they'll look at the effect of physical activity on heart disease, the effect of systolic blood pressure on heart disease, so on and so forth. And they don't recognize that they have to kind of figure out how to put them all together so you don't end up relating more than 100% of heart disease to the risk factors. In fact, if you just add up the risk factors that we know are causally related to heart disease, you'll come up with over 250% of heart disease being explained. So obviously that's not possible. So we have to find some way to jointly estimate the effects in the real world out there when all these risk factors are in play with individuals and in the populations at the same time. The US healthcare spending was aggregated from public and private sources. It was quite a job to get it put together and clean it up and put it in the healthcare spending by disease. We had to do some work to use the global burden of disease attribution fractions in the healthcare space. But let me then run through very quickly a little bit of what comes out of these studies. And the next slide, please, Francois. I want to start with the mortality. These visualizations, the ones up on top, are what you can find in the global burden of disease. They've got an enormous amount of data, but they've done a fantastic job of turning them into visualizations that can help you kind of grasp what's in the data. On the left, that square depicts mortality in 2019, or the cause of death by each of these categories. And there's category, you can start very high level and you can dig down into more refined definitions of disease here, or of death. So what this does is this is at a fairly refined level. There's one more even deeper level. And on the left, it depicts by the size of the squares, the largest causes of death in 2019. And I've summarized them down below, and they are labeled with 1, 2, 3, 4, 5, just for purpose of looking at the top 5. You can see it on the bottom left. The largest is ischemic heart disease, and then across you can see that their model attributes the causative risk factor, the causative risk factors that are related to ischemic heart disease. The major ones are the 7 across the top there. High blood pressure, high cholesterol, high fasting plasma glucose, high BMI, tobacco, dietary risk, and there's some others where there's others. But what you find out of the 84 risk factors that are studied by global burden of disease, 5, 6, 7, 8 account for well over 90% of the relationships between risk factors and diseases. But you can see a little bit about the detail in the model there. On the right, the difference between the light and the dark blues in each of the boxes is the dark shadows that portion of each of these risk, or each of these causes of death that are attributable to the joint effects of all the risk factors listed on that chart in the lower left. So, for example, ischemic heart disease, which is in the upper left, 92.5% of deaths in 2019 were attributable to histories of high blood pressure, high cholesterol, high fasting plasma glucose, high BMI, tobacco, and a poor diet. And you can see that each of the major causes of disease are just hugely related to histories of these modifiable risk factors. And on the lower right, you can see if we aggregate all the non-communicable diseases, that the study shows that 64% of non-communicable diseases are related to histories of heightened risk factors. Each disease will have its own unique set of risk factors. You can see a little bit at the chart on the left. That's the biggest category, but in aggregate, the study attributes 61% of all deaths to histories of risk factors that can be modified. That's an enormous amount of opportunity for us if we can learn what these relationships are, and then how to address it with programs to help our insureds manage their risk factors. So mortality, this is a picture of mortality. Francois, if you would take the next slide, which is morbidity. Morbidity's a very different picture. Again, you have the two visualizations on the left the visualization of the various diseases that add up to 100% of the measure of morbidity from the global burden of disease in 2019. And on the right, for the top 5 conditions, some sense of what the attributable risk factor looks like for each of those pieces. And you can see on the bottom left, the list of diseases are very different, okay? So the things that cause people to have ill health are very different than the things that end up causing them to die. In the US, the most important things or the biggest things that are causing people to be living in some sort of degree of ill health are back pain, other musculoskeletal conditions, drug use disorders, diabetes, and depressive disorders. And you can see from that little chart the various modifiable risk factors that are causally related to those particular conditions. And when you look on the right, you can see that the percentage of each of those top 5s that are related vary quite significantly from what we saw with life insurance or with the mortality thing, all the way from the idea that musculoskeletal, which are the biggest cause of morbidity being measured in global burden of disease, even though it's the largest cause of morbidity, nothing is related to modifiable risk factors. But on the other hand, diabetes is very heavily related to modifiable risk factors. And when you take a look overall, the little chart on the bottom right, you can see that it should be all deaths, it should be all morbidity that's there. Is only 33.4% of the entire array of diseases are related to modifiable risk factors. Probably shouldn't say only, because 33.4% is a huge number, but if you recall what the life insurance was, it was 61%. So that much more of mortality is related to these modifiable risk factors than morbidity. So these are what we got from, or the data we had, the relationships we had from the global burden of disease study. Then we took the next step of looking at healthcare spending and taking the information from these 2 studies I just covered very quickly, looking at their applicability to healthcare spending in the United States. And Francois, if you'd go to the next slide, please. This is a slightly different form, and because I think it does a much better job of kind of giving us an overview. The same kind of charts that were on the other pages, those little squares with everything on them, also exist on the Global Burden of Disease website for healthcare spending, but it is so noisy that you can't make sense out of it. So this is another way of presenting the disease. On the left, you can see the age. Oh, by the way, this is based on breaking out $1.7 trillion of total healthcare spending in the United States. And yes, that is trillion, it's a big number, but it's broken out by age on the left, and then it flows through by age as either spending that's related to modifiable risk factors, which is the blue, or spending not related to modifiable risk factors, which is the gray. You can see how it flows from the age to the type to the condition, the major conditions. Now, these are slightly different level of conditions than I showed you before, but I can give you some relationships just to kind of put it in perspective. But the most spending and related spending is on musculoskeletal disorders. And on my thing, this is broken, I need to get mine. Okay, for musculoskeletal disorders, out of that $2.7 trillion, $380 billion is spent in that category. And when you look at the risk factors with the modifications we made, we find that 21.9% of those spendings can be attributable to risk factors. Diabetes is the second largest group. cardiovascular disease, communicable disease, and you can see on the right that percentage of that spending which is related to these risk factors. Okay. Now, just to kind of put a little bit of perspective across one, if we looked at ischemic heart disease, which was the largest cause of mortality, I won't go back to the other slide, I'll just quote you some numbers over there, but of total deaths in 2019, ischemic heart disease accounted for 18.9%. Okay, if you looked at the years lived with disability for that same condition, it's only 0.6%. So 18.9% of deaths really were driven by 0.6% of the total years of loss to ill health. And the spending related to those 0.6 years in ill health was 3.3% of healthcare spending. So you have quite a bit of difference as you go through the various measures, and you could play with this forever, but we don't have time to, so I would just kind of point you again to the Global Burden of Disease website. Francois, can we go to the next, please? I'm not going to cover this, you can get on the slide, but this is a breakdown of the spending by risk factor, and you can see the most costly risk factors are high blood pressure, high BMI, high fasting plasma glucose, dietary risk, and tobacco smoking. And you can look through the details of what diseases are related to them. Next slide, please. And this breaks down within each of those by age. And the message here is that there's not much money, not much spending, not much money to be saved at younger ages. You start getting significant opportunities to intervene and save money when you get to ages, middle ages, 45 to 64, or when you get to the older ages. Next slide, please. Also on the website, when you go, they've been able to break down the causes of increase over time from 1996 to 2003 is on the IHME website. And there's just kind of a wealth of data into looking at what the drivers are of changes in the spending over that period of time. And it's broken down by the type of care, which you can see here. Unfortunately, we don't have time to spend going through all this in detail. I apologize, but again, this is really a high level view, and I have to the extent this is something that's interesting, you need to go to the IHME website. Francois, my last slide, please. Okay, what did we learn? Reducing modifiable risk factors has a very strong potential to significantly reduce healthcare spending. If we lived in a counterfactual world where all these 84 modifiable risk factors were at their theoretical minimum, which we don't live in and will never live in, we would save 27.0% of healthcare spending in 2016. That won't happen, but if we could just save a portion of that, it's a big deal. And when you look at the adults, the other thing we learned is we learn which risk factors are the most important. We learn what ages we can intervene at to have the most effect, and we can learn more about what diseases are related. So there's a wealth of information that can be had here that I would put forward to all of the actuaries on the call. Has a great deal of influence on your thinking about how to move from the historical world where there was no intervention by risk bearers and the health of individuals into the world that we're living in now, where we're learning how to intervene, how to save money for the individual, how to save money for the insurance company. It's a really wonderful model, and Francois is going to try and wrap up with some concluding remarks on the model, how it all fits into insurance.
Great, Howard. Thank you so much. Howard, just one correction. The material in our paper is available on the Lancet website. It's an open access paper. It's pretty much the title of the slide and the session. So you can find it on the Lancet, and I believe that the slides will also be shared with participants. I just quickly want to conclude. Chapter 3 is why is this important to us? Why it's important to us as a business? Why I think it's important to insurance companies in general, and also to us as actuaries. We think we see the world is increasingly changing. So behavior, we believe, play a critical role, as hopefully we demonstrated here. Technology is starting to make it more and more, or enable our systems more and more to be able to get the data, to look at these things, but also to make a really material impact in people's lives. And I think people are really starting to expect more of our companies to have a purpose. I mentioned earlier when we started, there were a lot of questions. Why should insurance companies care about this? Why should we as actuaries care about this? And I think as I said, we have moved on. What I still see companies struggle with is the why. A lot of companies are just going into the how and the what. Okay, if I couple some of these things to my insurance products, then I've got a solution and so on. We would say that the why of the model is critical to execution. Many of you are familiar, and those who are not familiar with our business model. Our core purpose is to make people healthier and to enhance and protect their lives. We see that fundamentally as demonstrated in a shared value insurance model, which is a business model where we can do better as a company if our people can do better, and we can influence societies where we apply that at scale. It's very well demonstrated in other industries. And that's why this is critical for us. It gives us a good lens to look at our own products, and also to structure our own data to build on these things, which we will come out with more products and so in the near future. But it keeps us honest. And I think that's critical for obviously any actuary's work. We're skeptical by heart. There's a good structure, great collaborations, and it's really sitting at the center of our business model. So in the interest of time, I'll stop there. And just again, thank you so much for your time. It's always a pleasure to talk about the stuff. Not sure if there are any questions, and if someone's going to moderate.
Yeah. So thanks for the presentation. I think we have some questions that has been posted. So one of it is by Selwyn. Some of the modifiable risk factors may not be so modifiable as they are strongly influenced by socio-economic status or education. Have you looked at adjusting for some of this, or have a view on which factors are most easily modifiable?
Definitely, that's the kind of a next level of digging in here. Some things are easier to change than others, and correctly understanding the distribution of some of these risk factors, because they are different by socioeconomic status, can really help you kind of understand things. So the data that we presented is just a starting point for a real in-depth deep dive into why these risk factors are modifiable and causative, and what you can do about them. And a good example is tobacco smoking. It's very difficult to get somebody to stop smoking. Okay, it's much easier to get somebody to do more physical activity. So you really have to go through each of the risk factors, understand it in depth, understand what it is that we can do in order to encourage people, to incent people to change, and to reinforce whatever changes are made.
Yeah, and I'll just quickly jump in there. It's a great question, and it's something we're really passionate about. I think if you look at socioeconomic factors and social determinants of health, all of these risk factors start to explode in populations, in lower socioeconomics and so on, which means our impact as an insurance industry can be a lot bigger. Our ability to bring technology to make these things accessible and to incentivize people to have better behaviors can be bigger in these relationships. Business models should be more supported by it. It's something we're looking at very seriously, and we see great opportunity. But having said that, it's also very challenging. These populations are some of these populations are very challenging. It often takes collaboration between private and or between your government and insurance sector, such as what is demonstrated in the US for Medicaid, for example. We believe there are business models that can sustain that, but I think we both see it as a responsibility and a opportunity for insurance companies to step up.
Right, cool. Also another question, perhaps more from myself. How much of the IHME studies can be extrapolated to other markets, and what kind of adjustment is needed if that is to be done?
Yeah, please remember that they do it for 195 countries, so you can get data directly related to pretty much every country that's represented on this call. If you're looking for the healthcare costs, that you can't do, so that's a little bit more of a challenge to think about the study that we did in the U.S. healthcare costs and how that might affect healthcare costs in a different country. But the mortality, morbidity is directly related. The challenge is, and I want to underline this is population data. So to the extent that the insurance company is insuring a higher socioeconomic group, you've got to adjust somehow for the differences between general population and an insured population. Can be done, but it's tricky.
Right. So another question that was asked was, how would you suggest insurer or reinsurer to make use of this study to improve morbidity and mortality risk? Would that be via wellness programs like Vitality?
Yeah, I don't like the word wellness programs in particular. I think it comes with some bad connotations. But effectively, what you're saying is if you have some sort of relationship with the individual and can explain to them what the risks are, give them incentives to change their lifestyle, to change those things that are modifiable, and somehow reward them for doing those things. Now, instead of just being a passive institution that tries to estimate what the QXs or the morbidity are and build it into the premiums, we're working with the individual to improve their mortality, to improve their morbidity, and ideally passing along the savings back to them in lower premiums, and while retaining a nice profit for ourselves.
Yeah, maybe just to jump in there, I think as actuaries, we see ourselves great with risk management, right? But the risk management tends to be internal. It's enterprise risk management. So how do we manage capital, our finances, our reserving, our solvency? This is real risk management. Is how do you manage the risk of your population, and what does that do on your block? So that's maybe one way, especially where there's a bit of resistance in the companies, and so is to think about it just from a traditional risk management framework. This is all we're doing. We're trying to manage risk. We're just saying we know that there's internal risk, there's external risk. How can we better manage and incentivize external risks and get better business outcomes from that?
Right. So maybe linking to this is also the use of health tech and to provide feedback and monitoring. Do you think that this will help to uncover new risk factors?
Yeah, I'll quickly jump in. I think there's a lot of noise in the system. It is worthwhile to quickly just scan that paper we did for the SOA, where we kind of went through these things are robust, this is emerging evidence on some things. And I think it's useful to have a holistic framework to bring things together. I actually think the points Ian made yesterday, if you guys had the opportunity to listen to Ian's discussion, was brilliant, where he said, if you want to change, for example, the healthcare system, you need to look at three things: data analytics, you need to look at the payment models, you need to look at behavioral economics. I think, and some of your panel in the earlier session articulated it. If you want to make a difference in people's lives, the big things are there. I mean, we just talked through the big things that's going to matter. I mean, some of these other things are on the margins. But it's hard to change. You need to get into consumer experience. You need to really get into the why if you're getting into consumer engagement and so on. And you can use a lot of technology. And I think technology is going to continue to expand. As Ian said, there's still a divide between the system how systems work and how consumers use technology. But in life insurance, it's expanding quicker, ironically. I think the use of Apple Watch in terms of predicting certain outcomes is becoming very interesting. And there's a lot of technology that's going to help us, but it's going to help us address these traditional factors better. I think from what I articulated in our model, we believe incentives will remain a critical part of that, really bringing the why for the person into the equation.
Very quickly, let me just try and use this to make a point. I think the thing that these studies do more than anything is it organizes a complex, very difficult to understand set of factors, between modifiable risk factors, biometric risk factors, mortality, morbidity. You need some sort of way to comprehensively put things together. And the huge value of the IHME model is that it's all there in one place with strong definitions, and you can kind of study the thing at various levels of depth. And more than anything, it's having that knowledge and understanding what's important, what's less important, what's noise, how the pieces come together, not overcounting, are all the kinds of lessons that you can learn by looking through this data. And they're all terribly applicable in life insurance, health insurance, if what you want to do is, instead of passively just insuring people, intervene in their lives, help them do a better job of living longer and living healthier.
Right. Okay. Thanks for the presentation.